Hello, brilliant nurses in the making. Welcome back to NCLEX, where your daily dose of high-yield nursing mastery comes alive. We upload 2 to 3 powerful NCLEX videos every single day, each one designed to simplify critical concepts, strengthen your clinical judgment, and bring you one step closer to success. In today's video, we are focusing on an incredibly important and exam-relevant topic: nursing care of clients with upper respiratory tract conditions. This session will walk you through the assessment findings, medical management, and priority nursing interventions for conditions like the common cold, sinusitis, pharyngitis, tonsillitis, and laryngitis. You will also learn how to recognize red flag symptoms that indicate airway compromise and how to apply NCLEX-style reasoning to real-world nursing scenarios. So grab your notes and stay tuned till the end, because every minute here adds to your nursing power. And remember, at NCLEX, we are not just helping you pass the exam. We are building the next generation of confident, compassionate, and clinically sharp nurses. Let's begin today's journey with a clear breath into the world of upper respiratory tract nursing care.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get: 100-hour mini crash course perfect for those who want to pass within a week, 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested, 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us now shift into a very practical clinical teaching moment that tests a nurse's ability to provide patient education about antibiotic use. A 38-year-old client visits the outpatient clinic complaining that their physician refused to prescribe antibiotics for a head cold. The client seems frustrated, saying, "Every time I get congested and have a sore throat, I need antibiotics to get better." As the nurse, what is the most appropriate explanation to help the client understand the physician's reasoning? Here are the possible options. Option A states that antibiotics are ineffective in treating viral infections. Option B suggests that antibiotics lose their effect once cold symptoms begin. Option C explains that antibiotics only prevent the spread of colds to others. And Option D mentions that antibiotics are reserved for immunosuppressed individuals. The correct answer is Option A: antibiotics are ineffective in treating viral infections. When we look deeper, this rationale emphasizes a crucial concept in infection control and pharmacological safety. The common cold, known medically as acute viral rhinitis or coryza, is caused primarily by rhinoviruses, coronaviruses, and adenoviruses. These are all viral pathogens, which means antibiotics, designed specifically to destroy bacterial cell walls or interfere with bacterial protein synthesis, are useless against them. Because viruses replicate inside host cells, antibiotics cannot reach or affect their life cycle. This misunderstanding is extremely common among clients who associate antibiotics with any kind of illness relief. Overprescribing antibiotics has significant consequences. It promotes antibiotic resistance, allowing bacteria to mutate and survive future treatments, giving rise to dangerous multidrug-resistant organisms such as MRSA and VRE. It can also disrupt the gut microbiome, leading to diarrhea or opportunistic infections, such as Clostridioides difficile colitis. Moreover, allergic or toxic reactions may occur, offering no therapeutic benefit in viral illnesses. Therefore, nurses must play a vital role in teaching patients that the common cold resolves naturally within 7 to 10 days, and that supportive measures, such as hydration, rest, humidified air, saline nasal sprays, and over-the-counter analgesics, provide the best symptom relief. Antibiotics should only be considered when signs of secondary bacterial infection appear, such as persistent fever, purulent nasal discharge, or ear and sinus pain following initial viral improvement. As for the other options, Option B is incorrect because the ineffectiveness of antibiotics in this case is not about timing. It is about the nature of the pathogen. Option C is also wrong since antibiotics cannot prevent viral transmission. Prevention depends on proper hand hygiene and respiratory etiquette. Finally, option D is inaccurate because immunosuppressed individuals might receive antibiotics prophylactically for specific bacterial infections, but not for a simple viral cold unless bacterial superinfection is confirmed. Now, moving into our stand-coast clinical insight, patient education about antibiotic misuse is not just about one prescription. It is about protecting future generations from resistant superbugs. Each unnecessary antibiotic taken today increases the global risk of untreatable infections tomorrow. And transitioning into the stand-coast high-yield NCLEX Pearl, always emphasize that antibiotics treat bacterial, not viral, infections. Encourage symptom management, monitor for secondary bacterial signs, and promote judicious antibiotic stewardship, a key NCLEX concept under the categories of infection control and pharmacological safety. As we move into another insightful clinical question, let us explore a case that tests your ability to recognize early warning signs of complications. A 42-year-old client reports symptoms of a common cold, including nasal congestion, mild throat irritation, and fatigue. 2 days later, the client contacts the nurse stating that their fever has increased to 103 degrees Fahrenheit, 39.4 degrees Celsius, and they now feel short of breath with a productive cough. Which symptom reported by the client is the best indicator that complications are developing from this cold? Here are the options to consider carefully. Option A is nasal stuffiness, option B is dry cough, option C is high fever, and option D is scratchy throat. The correct answer is option C, high fever. When assessing a client with an upper respiratory infection such as the common cold, the nurse must differentiate between mild viral symptoms and those suggesting bacterial superinfection. A high fever exceeding 102 degrees Fahrenheit after an initially mild illness strongly indicates that the client may have developed a secondary bacterial infection, such as acute bronchitis, sinusitis, or community-acquired pneumonia. Typically, viral infections cause only a low-grade fever and mild systemic symptoms, while a sudden temperature spike with worsening cough or thick, purulent sputum points toward bacterial involvement in the lower respiratory tract. Therefore, the nurse's assessment should focus on auscultating breath sounds for crackles, observing sputum color and consistency, and monitoring oxygen saturation. Prompt provider notification is crucial because antibiotics should only be used when bacterial infection is confirmed. Recognizing this progression early helps prevent serious complications, such as sepsis, respiratory failure, or chronic bronchial inflammation. Now let us review why the other options are not correct. Option A, nasal stuffiness, is a typical early symptom of the common cold caused by inflammation of the nasal mucosa and increased mucus secretion. It is a benign and expected finding unless it is associated with sinus tenderness or thick, colored drainage. Option B, a dry cough, results from post-nasal drip irritating the throat and usually resolves with adequate hydration and humidified air. It does not suggest disease progression. Option D, scratchy throat, occurs from viral inflammation and mouth breathing during nasal blockage. It is generally self-limiting and resolves on its own. Only if the throat becomes exudative or extremely sore would further testing, such as a throat culture, be warranted. Transitioning now to your key clinical reflection through the stand-coast clinical insight. When a mild viral cold suddenly brings a high fever, think bacterial superinfection, not just worsening discomfort. Early detection and prompt communication can prevent pneumonia before it develops. Moving forward to your stand-coast high-yield NCLEX Pearl. For NCLEX and clinical practice, always focus on the pattern and progression of symptoms rather than isolated findings. A viral cold generally presents with a low-grade fever, clear mucus, and mild fatigue, whereas bacterial infection leads to high fever, purulent sputum, chest pain, and worsening weakness. Nurses must teach clients to seek medical attention if fever exceeds 102 degrees Fahrenheit, cough becomes productive, or shortness of breath appears. These are hallmark signs that the infection has moved beyond the upper airway. Let us transition smoothly into this next advanced clinical reasoning question that challenges your understanding of safe over-the-counter medication use. The question asks, before recommending the use of a non-prescription decongestant to a client with symptoms of the common cold, which aspects of the client's medical history should the nurse assess carefully? The available options are as follows. Option A is arthritis, option B is asthma, option C is hypertension, option D is diabetes mellitus, Option E is glaucoma, and option F is cardiac arrhythmias. The correct answers are option C, hypertension, option E, glaucoma, and option F, cardiac arrhythmias. When a client seeks quick relief from nasal congestion, the nurse must think beyond surface-level symptom management and consider how underlying diseases interact with over-the-counter decongestants. Most decongestants contain sympathomimetic agents such as pseudoephedrine or phenylephrine. These agents stimulate alpha-adrenergic receptors in nasal blood vessels, causing vasoconstriction that reduces swelling and improves airflow. However, this same mechanism can lead to systemic vasoconstriction, which may dangerously elevate blood pressure and heart rate in certain clients. Option C, hypertension, is particularly critical because adrenergic decongestants increase systemic vascular resistance, which may result in severe hypertensive episodes or even cerebrovascular accidents in individuals with uncontrolled blood pressure. Option E, glaucoma, especially narrow-angle glaucoma, poses another risk since adrenergic stimulation can dilate pupils and elevate intraocular pressure, potentially causing acute vision loss. Similarly, option F, cardiac arrhythmias, must be screened for because these medications can activate beta-adrenergic receptors in the heart, resulting in palpitations, tachycardia, or even exacerbation of pre-existing arrhythmias or ischemia. In contrast, option A, arthritis, and option B, asthma, are not direct contraindications unless the client is taking medications that could interact with adrenergic compounds, such as corticosteroids or beta agonists, necessitating cautious use. Meanwhile, option D, diabetes mellitus, should be approached with vigilance, but is not an absolute contraindication. Adrenergic stimulation can elevate blood glucose by promoting glycogen breakdown and reducing insulin secretion. So, diabetic clients should be advised to monitor their blood sugar closely during decongestant use. Transitioning to the Stand-Coast clinical insight. Before recommending even a seemingly harmless cold medication, nurses must appreciate the hidden dangers of sympathomimetic drugs in clients with cardiovascular or ocular conditions. A brief but comprehensive medical history can make the difference between safe symptom relief and a life-threatening complication. Moving into the Stand-Coast high-yield NCLEX Pearl. Always assess for hypertension, glaucoma, or cardiac arrhythmias before suggesting over-the-counter decongestants. Remember, non-prescription does not mean risk-free. Educate clients to consult healthcare providers for proper symptom management, emphasizing safety, prevention, and individualized care. Let me share something before we jump in.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us move on to an essential concept that every nurse must understand when educating clients about self-administered nasal medications. The question asks, when teaching a client about the use of topical nasal decongestant sprays, which adverse effects should the nurse emphasize as a risk of excessive or prolonged use? Here are the options to consider. Option A suggests nasal irritation with rhinorrhea. Option B states rebound congestion with nasal stuffiness. Option C mentions ulceration of the nasal mucous membranes. And option D refers to a decreased ability to fight microorganisms. The correct answer is option B, rebound congestion with nasal stuffiness. When teaching clients about topical nasal decongestant sprays, the nurse must emphasize that overuse can ironically worsen nasal blockage, a condition known as rebound congestion or rhinitis medicamentosa. These sprays, such as oxymetazoline and phenylephrine, work as sympathomimetic alpha-adrenergic agonists that constrict nasal blood vessels, bringing quick relief by shrinking swollen mucosa and reducing mucus formation. However, when used for longer than 3 to 5 days, the nasal blood vessels adapt and become less responsive to the medication. As the effect fades, compensatory rebound vasodilation occurs, leading to swelling, congestion, and dependency on the spray for temporary relief. This cycle of congestion and overuse forms a common pattern in clients who misuse these drugs. Rebound congestion occurs due to ischemic irritation and desensitization of alpha receptors within the nasal mucosa. Over time, chronic use may cause mucosal inflammation, persistent congestion, or even turbinate hypertrophy, making the condition difficult to reverse. Nurses should advise clients to restrict decongestant use to no more than 5 consecutive days, to discontinue gradually if dependence develops, and to consider non-adrenergic alternatives such as saline sprays or steam inhalation for long-term nasal comfort. Meanwhile, option A, nasal irritation with rhinorrhea, may appear as a temporary and mild side effect due to dryness or sensitivity, but is not the hallmark adverse effect of overuse. Option C, ulceration of the nasal mucous membranes, is more commonly associated with repeated mechanical irritation, such as aggressive nose blowing, not drug-induced vasoconstriction. Option D, decreased ability to fight microorganisms, is inaccurate since topical decongestants do not suppress immune function or increase infection risk. Transitioning to the stand coast. Clinical insight: short-term nasal relief should never turn into long-term dependency. The key to preventing rhinitis medicamentosa is patient education. Limit spray use to fewer than 5 days and shift to safer, non-adrenergic options when needed. Moving forward to the stand coast, high-yield NCLEX Pearl. Always remind clients that the more they use, the worse it gets with topical decongestants. Encourage the 3-day rule, promote saline nasal irrigation for chronic congestion, and closely observe for signs of rebound, such as persistent stuffiness despite frequent spray use. Let us continue with another high-yield clinical teaching scenario that highlights preventive nursing care in everyday conditions. A nurse is teaching a client recovering from a head cold about ways to prevent complications. The question asks which recommendation is most appropriate to reduce the risk of developing a secondary middle ear infection. Here are the options to consider. Option A suggests sleeping with the head elevated. Option B advises blowing the nose very gently. Option C proposes inserting cotton into the ears. And option D mentions massaging the area behind the ears. The correct answer is option B, blowing the nose very gently. When educating clients with a simple upper respiratory tract infection, such as a head cold, it is vital to emphasize gentle nose blowing as a preventive measure against secondary ear infection. The eustachian tube, a narrow passage connecting the nasopharynx to the middle ear cavity, plays an essential role in equalizing air pressure and draining secretions. During a cold, inflammation and congestion of the nasopharyngeal mucosa can cause the eustachian tube to become partially blocked. If the client forcefully blows the nose, the increased intranasal pressure can push infected mucus or pathogens from the nasopharynx directly into the eustachian tube. This process introduces microorganisms into the sterile middle ear, leading to otitis media, characterized by ear pain, hearing loss, and possible tympanic membrane inflammation or rupture. In contrast, gently blowing one nostril at a time minimizes internal pressure changes and helps clear mucus without forcing secretions into the middle ear space. This simple teaching significantly reduces the likelihood of infection spread and promotes safe nasal hygiene during upper respiratory infections. Option A, sleeping with the head elevated, can indeed aid sinus drainage and relieve nasal congestion, but does not directly prevent a middle ear infection. It may enhance comfort, yet it lacks a specific protective effect on the eustachian tube pathway. Option C, inserting cotton into the ears, is both unnecessary and potentially harmful. Cotton can trap moisture and microorganisms, creating an environment conducive to external ear infection, or otitis externa, rather than preventing middle ear infection. Finally, option D, massaging the area behind the ears, has no physiological impact on eustachian tube function or infection prevention and may give clients a false sense of protection. Transitioning to the stand coast clinical insight. Here is a powerful takeaway for every nurse to remember. Preventing ear infections starts with airway pressure control, not ear protection tricks. The eustachian tube acts as the gateway between the nose and ear. Teaching gentle nasal hygiene can literally close that gateway to infection. Now moving on to the stand coast high-yield NCLEX Pearl. Before you proceed, keep this golden NCLEX fact in mind. Forceful nose blowing propels pathogens into the middle ear. Always instruct clients to blow one nostril at a time, maintain good hydration to thin secretions, and use warm compresses or saline sprays to promote safe nasal clearance. Let us move into the next insightful clinical scenario that focuses on identifying sinus involvement through pain localization. A client reports experiencing persistent nasal congestion, low-grade fever, and facial tenderness following an upper respiratory tract infection that has lasted for more than 10 days. Upon examination, the nurse observes purulent nasal discharge and a dull ache radiating toward the upper jaw and teeth. Based on these findings, the nurse suspects inflammation of which sinus cavity? Here are the options to consider. Option A refers to the frontal sinuses. Option B mentions the ethmoid sinuses. Option C highlights the maxillary sinuses. And option D indicates the sphenoid sinuses. The correct answer is option C, maxillary sinuses. Sinusitis, also called rhinosinusitis, is an inflammation of the mucosal lining of one or more paranasal sinuses. It often follows an upper respiratory infection, which leads to mucosal swelling and obstruction of sinus drainage, creating an ideal environment for bacterial growth. The maxillary sinuses, being the largest and located within the maxillary bones just beneath the cheeks, are especially prone to infection because their natural drainage opening lies high on the medial wall, allowing secretions to pool easily. This causes a dull, heavy ache or pressure in the cheek area that often radiates to the upper teeth or jaw due to irritation of the maxillary nerve branch, CNV2, the infraorbital nerve. This classic radiation pattern is a key diagnostic clue that helps nurses differentiate maxillary sinusitis from other sinus infections. On the other hand, frontal sinusitis typically produces pain above the eyes and forehead. Ethmoid sinusitis causes discomfort between the eyes or at the nasal bridge with possible periorbital swelling. And sphenoid sinusitis, though rare, presents with deep pain behind the eyes or at the top of the head. Recognizing these pain patterns allows nurses to accurately identify the affected sinus and anticipate potential complications such as orbital cellulitis or meningitis if the infection spreads. Transitioning now to the Stancoast clinical insight, maxillary sinusitis pain radiates toward the upper teeth because the roots of the molars lie close to the sinus floor. This is why clients sometimes confuse sinus pain with dental pain, a subtle but important diagnostic clue every nurse should remember. And moving forward to the Stancoast high-yield NCLEX pearl. When sinusitis symptoms persist for more than 10 days, it usually indicates bacterial infection rather than a viral one. Nurses should teach clients to stay well hydrated, use warm steam inhalation, and avoid forceful nose blowing to promote sinus drainage and prevent middle ear complications. Before we begin, I want to share something that has already helped more than 100,000 nursing students achieve success.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us continue our NCLEX-style journey with a practical teaching scenario that focuses on client education for nasal medication administration. A nurse is instructing a client diagnosed with allergic rhinitis on how to properly self-administer nasal drops. The key question asks which instruction the nurse should emphasize to ensure maximum therapeutic effectiveness and proper medication distribution. Here are the options to consider. Option A advises the client to bend their head forward and instill the drops into their nostrils. Option B recommends pushing the nose laterally before instilling the drops. Option C suggests tilting the head backward while instilling the drops. Option D directs the client to turn the head to one side while instilling the drops. The correct answer is option C. Tilt your head backward while instilling the drops. Here is the expanded advanced rationale. When administering nasal drops, correct head positioning is critical for delivering the medication to the appropriate region of the nasal passages and nasopharynx. Tilting the head backward utilizes gravity to allow the liquid medication to travel deep into the posterior nasal cavity, ensuring uniform coating of the mucosa and optimal absorption at the target site. This position allows the medication to reach the superior and posterior turbinates, enhancing the anti-inflammatory or decongestant effects based on the drug used. In contrast, bending the head forward would cause the drops to flow outward through the nostrils, reducing retention time and therapeutic benefit. Pushing the nose laterally or turning the head sideways might cause uneven distribution or direct the drops into the throat instead of coating the nasal lining. To maximize absorption, the client should keep the head tilted backward for 2 to 3 minutes after installation. The nurse should also remind the client not to blow their nose immediately after administration, as this could expel the medication before it has been absorbed. Moreover, the client should gently clear nasal passages before using the drops, either by lightly blowing the nose or using a saline spray, to ensure direct mucosal contact. For corticosteroid drops, it is essential to insert the dropper tip gently inside the nostril without touching the mucosa, as contact can lead to contamination or mucosal injury. Now moving on to an important professional insight, stand coast. Clinical insight reminds us that medication efficacy in nasal therapy depends as much on gravity and anatomy as on chemistry. Teaching clients to tilt the head back transforms a wasted dose into effective symptom relief. Finally, transitioning to our high-yield exam takeaway, stand coast. High-yield NCLEX Pearl emphasizes that nurses should always teach clients to tilt their head backward during nasal drop administration, remain in that position for several minutes, and avoid nose blowing immediately afterward. This ensures the medication remains in contact with the mucosa long enough for absorption, prevents loss into the throat, and maximizes therapeutic effectiveness. Let us move ahead with another highly practical clinical teaching scenario that blends infection control with safe home care practices. A 72-year-old client's spouse brings them to the clinic, reporting nasal congestion, sore throat, and low-grade fever, consistent with an upper respiratory tract infection. The spouse mentions having a cool mist vaporizer at home and plans to use it to relieve nasal congestion. The nurse must decide which instruction is most essential to emphasize regarding vaporizer use. Here are the options to consider. Option A warns that the vaporizer may cause injury if it is accidentally knocked off the nightstand. Option B advises that water left standing in the vaporizer can promote pathogen growth. Option C explains that dust accumulation on the vaporizer may worsen breathing difficulty. Option D informs that water evaporation can lead to calcium deposits obstructing the device. The correct answer is Option B, advise that water left standing in the vaporizer can promote pathogen growth. Now let us explore the expanded advanced rationale behind this correct choice. When providing teaching about vaporizer use at home, the nurse's highest priority is to prevent infection. Cool mist vaporizers and humidifiers are beneficial for loosening secretions and soothing irritated mucous membranes, especially in older adults. However, stagnant water left inside the chamber becomes a perfect environment for microorganisms such as Pseudomonas aeruginosa, Legionella pneumophila, and fungal spores like Aspergillus. Once these organisms multiply, the mist produced by the vaporizer can disperse infectious particles into the air, which may be inhaled, leading to pneumonia, bronchitis, or systemic infections in elderly or immunocompromised clients. Therefore, it is critical to teach caregivers to empty, rinse, and disinfect the vaporizer after each use, using a mild antiseptic or a vinegar water solution, and then allow it to dry completely before refilling. Furthermore, distilled or sterile water should be used instead of tap water, since minerals in tap water encourage biofilm formation that shelters bacteria, while other concerns, such as the risk of burns from warm mist vaporizers, option A, or calcium deposits, option D, may occur. They are not as immediately dangerous as the risk of bacterial contamination. Dust accumulation, option C, can affect efficiency, but does not directly increase infection risk. Hence, option B directly addresses the most urgent safety issue, preventing microbial growth and subsequent respiratory infections. Before we wrap up this discussion, here comes your Stand Coast clinical insight. Moisture soothes airways, but stagnant moisture spreads disease. The difference between therapy and threat lies in how well we clean what we use. And now, your Stand Coast high-yield NCLEX Pearl. Always teach clients and caregivers to use only distilled or sterile water in cool mist vaporizers. Empty and disinfect the chamber daily, and replace filters as recommended. Failure to do so can aerosolize harmful bacteria like Legionella, leading to serious respiratory infections.